Thank you, Ali, and thank you for the invitation. And as they say, it's never the money, it's just the money. If I can have the first slide. I think I just want to start off with one issue that I think gets confused when you talk about an ERAS program. Everything in these programs is cost reduction. You're not doing things. There's very little extra you have to do in these programs, and I think that's what gets confusing. These are my disclosures. So you saw this slide earlier, and it's meant to be small because all you need to do is see the yellow line at the top. Bowel surgery disproportionately accounts for the majority of surgical complications amongst all of our colleagues. So there's plenty of things to fix in colon surgery, and a lot of the things that we talked about today address many of these really, truly preventable complications. So this is US data, and they're, I think, in DC voting today. I'm not sure what they did to us today, but glad we're here. We don't have to hear about it. But this is the current economic payments for our DRGs. 331 is healthy, no complications. 330 is either sick with a number of comorbidities, or I made them sick after surgery, or in 329 is the emergency operations. You can see the difference in reimbursement. So you need to have a care plan as you devise it that can fit the lowest common denominator. That's that 331. You can't have a plan that's designed to take care of the 330 patients because you'll lose money on all the other group. One other issue here that often gets confused, and this is a little more of a unique issue in the States where you have to contract and compete with other providers. There is very good data, and we actually did a study on this before. If your patient comes in A331, they're healthy, and they have a significant complication that could have been averted and become a 330, and that happens more than the next institution, you're going to lose those contracts because those are preventable costs to the payer. You're preventing migration of the DRG and increased cost. So that's another reason to think very carefully, not only about your cost structure that you have to absorb, but the cost structure you're forcing on someone else by not managing complications well. So to paraphrase James Carville, it's the length of stay stupid. And the reason is, all of the things that lead to a longer length of stay are bad. There's really no good reason unless you have a beautiful facility with a nice view and it's free and they want to stay extra. That, I guess, is okay. But these are precious resources we're dealing with, and the goal is to get the patient out of the hospital safely, but not to use those resources so they're available for the next patient. And so every day, if you just want to improve your program, it's a simple question. What did I do today because the patient can't go home? That's a learning process for you. And a lot of these things, as you think about ERAS, are really local rules. There are things that you may face that the next person doesn't face with their ERAS program. There are 4 or 5 things that are consistent, but you need to be able to have that self-analysis each day to say, these are the learnings from today. What did I not do correctly yesterday that made the patient stay? So in the States, as you know, we have a bunch of process measures, things that we sometimes can't avoid doing, and a lot of things that people think we should be doing with cryptic data. But the best way to keep score is true outcomes. It's just like athletics. It's pretty clear who won, who lost. It doesn't matter how you won if you stayed within the rules. And I think a lot of the process measures that we're looking at don't directly tie to an outcome or may not even be able to produce that outcome. So once again, as you think about developing your own ERAS, you really need to be critical about each step. Is this really leading to something that I can measure? If it becomes religion, then you have to be very careful about, do you really want to put that in the program? It has to be something to easily keep score of, and you need to think ahead of time how you want to keep score. And clearly the cost of complications is important, but the cost of trying to prevent that complication, particularly if it isn't very effective, can't be very expensive, because if it's much higher than the cost of the complication, you're going to again have a negative cost structure. We've seen this scoring process before, and this is a very easy way to keep track of your program. This is something that all of your administrators would track in some fashion. You can put the clinical annotations yourself that fit each one of these categories, but you can start to see about the costs and then the activities that you try. Do they actually reduce the migration of these higher cost structures? Because if it isn't really doing it, then you're not accomplishing the goal, and you need to think critically about using it. So this is a different way to look at this. This is a way of business, hopefully not GM if you've been following the news lately, because For 20 cents, they could have solved a lot of troubles. But when you look at complications from a cost structure, this was a group of almost 400 colectomies. And so we looked at what were the episode costs of complications. So the greater than 3 complications, that's the one where the wheels come off completely, right? I have a leak, an abscess, they dehiss, they go to the ICU, they're on dialysis, all of those nasty things. Clearly that's expensive when that happens. Fortunately for me, that doesn't happen a lot. So when you look at that over the entire population, it was only $58. Now I would buy something for $58 that would prevent my anastomotic leaks, I can assure you, and I'd probably pay more than that. But we don't have anything that can prevent that complication precisely, so again, you have to think about adding something that has cryptic value to it. Conversely, we talked about postoperative ileus. There are some very effective strategies that are part and parcel of multimodal care. You get benefits in terms of analgesia, so you're getting multiple components of that care plan that fit into the cost structure to prevent postoperative ileus. And I'll show some data later why that's important. So again, if you look at the 23-hour-a-day protocol, again, it gets pretty elaborate. You don't have to read all the components. But really, this is, I think, the take-home message when you look at your care plan. There are nothing but benefits from an enhanced recovery. If the patient goes home safely, you use fewer resources to get that outcome. It is less expensive in total, and it is far better for the patient. There's just no argument about that. And so I think the critical point is you develop these programs internally, you need to always ask that question. How much does it cost to do it? What do you think we're making better? And how many resources does it take to implement? And if it's upside down, then you need to really forego it and do something simple to start with. But this is the other thing when you look at readmissions. I'm sort of the, I guess, pro-readmission guy, because I don't care about readmission as an independent variable. What I care about is total bed day consumption, because the readmission rate can be for a whole variety of reasons. And as you see here, even looking at a large group of patients retrospectively, knowing they were readmitted, we couldn't convince ourselves how we could have known that before. And many of these complications are not predictable nor preventable. So if I can't know it's going to happen and I can't stop it from happening, why should I be troubled with or burdened with the result of that? Simply bring them back in and we treat the problem and we get them back on the straight and narrow. But to hold somebody a certain number of days to lower a readmission rate for certain things doesn't make sense. And here's why it doesn't. If you look at the patients that had unplanned readmissions, we compared the reasons, and then we went back in a next study and compared that same complication that was found during the index hospitalization. So they didn't go home. We caught that before discharge and we treated it. On average, any given complication was found 1 day earlier in the readmission group, and the outcome was the same. So, and you know how that happens. Where do you come if you have a complication? You come to the emergency room, you go through the CAT scanner, and then they call the doctor. So you find the problem earlier, quicker. In the hospital, a lot of things can happen with delaying that diagnosis. So it doesn't, again, it doesn't prevent the complication from happening, nor does it make the outcome from that complication better. And this is the same for laparoscopic as well. It's almost the same, and whenever you see in a series, quote-unquote, bowel obstruction / ileus, almost exclusively that's a poor handoff of analgesia. They do your multimodal program in the hospital, and they go home and take their Tylox when they get home. And they stop taking the Motrin, and they stop taking the Tylenol, and they stop taking the Neurontin, and they only take the narcotic. That is a huge failure point for that handoff of when they go home, and why discharge instructions are so important. We already saw the data about discharge early. Again, to reinforce, it's not the people that go home early that bounce back. It's actually the patient you're a little nervous about. They aren't quite on the plan. They're going a little bit slower. Something isn't right about them. You keep them one more day. That's the group that actually somehow has the worst outcome. So I propose a much more simple program, and nothing on this list is expensive. So I don't use IV Tylenol because I give them a pill pre-op. I don't use IV Toradol because I give them a pill pre-op. So these things are much less expensive. They're easy to give. I'm on an oral regimen afterwards. The only thing I will take issue with is bowel prep. I still do one. And I do the old-fashioned Nichols-Condon, and I'll show you some data about that as well. This is important though, an instruction sheet. The patient needs to know what you're thinking and what their plan is and what they need to do to participate and what their likely trajectory is. So it looks normal to them as they go through, and when they don't hit that benchmark, then they know something isn't normal about them. So they kind of tip you off that something isn't right. And this, I'm not a big fan of the meetings and the consensus building and whatever. I'm sort of tainted from my athletic experience. I know that, you know, when I played football, the coach sent in the play, I was the quarterback, nobody got to talk in the huddle. If they didn't like the play, they could go talk to the guy on the sideline. And some of this is really, I think, once you agree on the order set, folks just have to follow the order set. You can take it offline and debate later, and you evolve it over time. But once the play is called, you have to do the play. You can't change it in the middle of the game. And I think that's one of the things that defeats ERAS. So I'll talk about bowel prep. So we've heard about the prospective randomized Cochrane studies and all that fancy calculus. The problem is none of the recent studies have done what Nichols and Condon did. They didn't include the third arm with oral antibiotics. And that's what makes all the difference for surgical site infection. It's only about surgical site infection. It was never about leak, only superficial infection. And all of the data subsequently that shows antibiotics decreases SSI. I've done it routinely, and I don't see all the other problems related to bowel prep. So all this concern about that, I'm not sure. I worry about that, and that's not part of my ERAS. POI, though, is a big thing. This is a huge problem. It's multimodal, but again, a number of the strategies that are inexpensive that we can roll into our ERAS, as we've heard today, dramatically decrease the ileus rate. And this is why it's important. This is a large group of colectomies, and we define post-op ileus very simply. Did the NG tube have to go back in, or were they made NPO? Because at that point, the care plan changes. They have to be on IVs. For surgeons, we're worried about a leak, so they'll get a workup for a leak. A lot of things drive the cost structure. We found that post-op ileus with no complication accounted for 40% of the total cost structure of the colectomy patients. So we had to save a lot of money on the other folks by not getting an ileus to pay for the expensive cost of an ileus all by itself. And this was reaffirmed by the MSQC data that showed a much lower risk of complications and a lower rate of ileus with the use of Alvimapan. We looked at it as Connor did earlier, looked at open and laparoscopic. The cost structure for laparoscopic is harder because we're very restrictive on narcotic dose, and the drug only blocks narcotics. So if the patient gets zero narcotics, a narcotic blocking agent can't be helpful. Conversely, my open patients still get some narcotics. It just can't be avoided. And here we dramatically change the overall ileus rate, and there I can make a very careful argument about cost effectiveness, and that's who we use it in. What about goal-directed therapy? Again, this is really fairly inexpensive. I'm sort of the anti-colloid guy as well, so I don't use all that expensive stuff. I use the stuff that costs 98 cents a bag, and that works pretty effectively. We found that goal-directed therapy, although they get more fluid usually in the operating room, over the course of the hospitalization it's dramatically less, and the complication rates are less, as you heard earlier today. So again, this is about using less expensive things more effectively and getting better results. We heard the religious arguments earlier about drains. So depending on which one you buy, this is between $85 and $250. So again, not using it saves you money. Doesn't make anything better clinically. So you're saving money again by not doing something that is heavily evidence-based. Epidural, I don't usually use epidurals for my laparoscopics. And in fact, we've kind of moved away from it for our open because of our pretty aggressive multimodal analgesic program. But here we found no benefit related to in laparoscopic patients for an epidural. So again, a cost savings, time and material that is cheaper for these patients. So overall, when you look at the adoption of an enhanced recovery protocol, you can use less things, you can focus your care better, and you can dramatically decrease the length of stay by carefully adopting laparoscopic and enhanced recovery protocols. But enhanced recovery protocols will still be important for your open patients. So the playbook is the same. Really, the care plan is almost identical for lap and open. It's just we know that laps will do better on average than the open patient. but they both do better than not using the enhanced recovery. So I'll be happy to stop here and look forward to the questions afterwards, but I think this actually goes a long ways in describing a lot of what we do, unfortunately, in medicine every day. And once again, thank you.